We'll now transition into our first session of the day, the gaps and barriers and exploration of what's missing. We're joined by Dr. Stephanie Mayfield Gibson, who's the director of the U.S. COVID-19 Response Initiative from the Resolve to Save Lives, an initiative of vital strategies. She's an executive level strategist devoted to responding to current and emerging health issues, pursuing priorities for higher quality outcomes and equity. Stephanie is a pioneer as the first woman and first African-American commissioner of the Kentucky Department of Public Health. During her tenure, she led the transformation of the largest healthcare delivery system in Kentucky and served as medical advisor to the Parent Institutions Initiative to address basic human needs across the total continuum of health. Throughout her career, she has vigorously responded to changes in an evolving economic and healthcare landscape. Dr. Gibson is an anatomic and clinical pathologist who earned her medical degree from Meharry Medical College. She completed her residency at the University of Louisville Medical School and completed executive leadership training at the Harvard Kennedy School. We're also joined by Mr. Nicholas Courtney, who is a policy analyst at the National Congress of American Indians and is an enrolled member of the Makah Nation. In his present position, he works directly with senior administration leadership, such as the director of the Indian Health Services, and staffs the Tribal Advisory Committee that directly advises the Secretary of HHS. He engages with members of Congress on health and other issues and works closely with Hill offices on policy and legislative development. He received his bachelor's and master's degree from Western Washington University in Bellingham, Washington. And we're also joined by Mr. Frederick Asasi, who is the Executive Director of Families USA. He has a lifelong commitment to achieving high quality, affordable health care for all. As the Executive Director, Mr. Asasi leads the expert staff at Families USA as the organization focuses on 4 key challenges: creating a value-based health system that ensures higher quality, lower cost health care, helping people overcome barriers to health and healthcare based on race, ethnicity, income, gender, demography, or sexual orientation, making comprehensive and affordable health insurance available to all, and empowering healthcare consumers to ensure that their voices are heard in their state and local communities, as well as in Washington, D.C. Mr. Asasi holds a JD from Duke University and an MPH from the University of North Carolina and a BS in cellular biology, a bachelor's in cellular biology, and a second major in Spanish from the University of Wisconsin. Thank you all for joining us today, and Dr. Gibson, will turn to you.
Yes, thank you, Ivory, for that kind introduction. Good day, all. I really appreciate being able to present to the National Academy of Medicine, and congratulations on 50 years to you on your anniversary. What an accomplishment. Congratulations. Okay, we can move to our first slide, please. Let's talk all things COVID right now. COVID has really highlighted inequities in our society. And as WHO stated, we're not safe until all are safe. We have a hand on everything, good and bad. And so this is going to require all of us to make a concerted effort to try to fight this virus. Second, please. Let's look at where we are now. We were just over 7 million cases when this slide was produced. Now we're at 7.8 million cases and growing, with 215,781 deaths recorded as of yesterday. We comprise 20% of the world's death total. Next. So COVID-19 and health insurance status, let's look at this now. We have 30.1 million uninsured people under 65 years of age in 2018. Now this number has unfortunately increased for a second year in a row, and now we have a backdrop of COVID-19. There were 27 million lost jobs and access to employer-sponsored health insurance within a few months between March and early May of this year, and 5% of US children in our country lack health insurance. Next, please. Here's a breakdown of some of the inequities when we talk about uninsured. And as you can see, 26.7% of Hispanic or Blacks, 15.2% non-Hispanic Black adults, and 9% non-Hispanic white adults. The discrepancy is growing with COVID-19. Next, please. Unfortunately, since COVID-19, routine preventive care has taken a dive. Child vaccination rates have plummeted, and one of our concerns in the world of public health, and should be to our entire nation, are we going to see an increase in viruses that we had put at bay secondary to vaccinations? We have for quite some time seen lower rates of all recommended vaccines in communities of color compared to whites, and now it's really more pronounced since COVID-19. The other we cannot forget about and remiss is that when we look at total health, we have to remember that it's physical and mental health and our social health. almost 28% of adults reported depression symptoms in a pandemic, and as compared to 8.5% pre-pandemic, which is greater in women. That is staggering right now. Next slide, please. COVID-19 and natural environmental disasters. I said this is a very complex scenario because nearly every year in the last 5 or 10 years, we hear of record fires and floods and other weather emergencies, and they have definitely increased our risk to housing disruptions, instability, economic instability, which can cause exacerbations of illnesses. And if people have to go into communal housing or even visiting with or living with relatives, you're getting increased risk of exposure. When you travel, the virus travels. And let's not forget again about the mental health impacts. 54% of adults and 45% of the children suffer depression after a natural disaster, and compound that on top of COVID-19. Next, please. We heard Dr. Odom Walker talk about unemployment and food insecurities, and this just underscores what she was saying. Here's the racial gap is widened for the 3rd month. In July, we had whites at 9.2% and non-Hispanic Blacks at 14.6% unemployment rates. Food insecurities, those of you SNAP in 2019, we saw an increase of 17% between February and May, and nearly 1 in 4 households experienced food insecurity in this year. Next, please. So what do we do? First of all, I want to level set. When we talk about equity, what is equity? Let me start by saying what it is not. Equity is not a program. What equity is, it's a systemic and thoughtful cultural change in an organization to develop and promote and sustain freedom from implicit bias across the entire organization. How do you do that? One of the things we did when I was Commissioner for Health, and this was our first iteration of this, we had a statewide health and all policies, and I always add practices, because what good is a policy if you don't practice? But convening all of the state secretaries and using their resources to look at goals, but hone in more on areas that are most at risk. We had significant success developing health and all policies with getting insurance access. Kentucky had done one of the best in the nation with ensuring and driving down uninsured rates. Now, we have to continue that effort throughout our nation and protect our health insurance. One of the things that another iteration would have been a natural consequence, particularly in light if we had had even a better vision of this COVID-19, would be to incorporate preparedness and readiness goals into a health and all policies, but looking at that through an equity lens and walking it across those social determinants of health for all communities. And that way, when we perhaps would not see if through coordinated federal and state responses, some of the discrepancies or inequities that we're seeing today with COVID-19. Improving publicly reported data is essential for impactive policy and intervention. One of the things we're seeing right now with COVID-19 is that the reporting may be irregular or not consistent coming from various states and districts, and trying to make a policy based on data that is not consistent can be a challenge for us. Promote health in communities across populations and countering misinformation real time. It's important to know where the best sources are and try to promote information that is science-based. And the more we can get that out and run that through our entire health and all policies and practices, we have an opportunity to achieving equity amidst something like COVID-19. Now, I hear people say, how do you in the private sector then talk about health and all policies and practices? Organizations all have some type of policy and practice, and understanding that this is a cultural, a systemic change that permeates throughout an organization is a first step forward in achieving equity, both with internal customers and external customers. So this next slide I would like to show you is based on I need your help with contact tracing for COVID-19. We're in an unprecedented time right now with this virus. We are hopeful that if we use certain measures, such as wearing a mask, watching our distance, and if we practice washing our hands and having alcohol sanitizer when washing hands is not achievable at the time, we have an opportunity then to drive this virus into a box and really box it in. And part of that boxing in means that contact tracing may be necessary. I know these words we're looking at may turn people off or wonder, is this going to be an invasion of my privacy? Contact tracers don't ask for your financial information. They don't want to find your resources for personal reasons. It is an epidemiologic investigation to try to keep you, your loved ones, and your community protected. So when public health contacts you, please answer the phone. This is the way that we try to put a virus at bay. One of the ways, it's a myriad. It's a comprehensive strategy to try to box in a virus. And we know that we have to test. We're going to have to isolate, contact trace, and quarantine as appropriate. Contact tracing, I know, is a labor and time intensive skill. It requires expertise, and it also requires cultural sensitivity. This is an equity meeting that we have, and it's important that when we talk about assisting jurisdictions with contact tracing, we keep in mind the population that we're contact tracing in. What are some of the cultural sensitivities that we need to be aware of in order to gain compliance, but trust first? There are new and emerging technologies around contact tracing, but what's tried and true is the traditional method of one-on-one trying to reach someone. And so what I'm asking you for is to help us, because our success is your success, and public participation and support is mandatory. The last slide I'd like to show you is, and ask you to please remember the 3 W's that we're reporting and asking people to comply with. Wear a mask, watch your distance at least 6 feet, and wash your hands and have hand sanitizer when washing hands is not permissible. This slide shows you what masks are best for COVID-19. And if you make your own mask, the tightly woven masks are more protected. Then you see what's not accepted. One of the things that I'm seeing, and if you could help us educate people, wearing a mask with a poor fit below the nose or under the chin is not protecting you or anyone else. So this is so important when you go into communities to inform people that wearing a mask is a defense. It's one of our knockouts for COVID-19, along with watching your distance and washing your hands. I thank the National Academy of Medicine for allowing me to give this update on COVID-19 and the inequities. And I ask that you please remember what to do to help us put this unprecedented virus in our country at bay. Thank you so much for this, Ivory, and the committee and Dr. McGinnis. Thank you.
Thank you, Dr. Gibson. Mr. Courtney, I'll turn to you.
Hi, thank you so much, and thank you, Dr. Gibson, for that fantastic presentation. And I echo the congratulatory remarks on 50 years to the National Academy of Medicine. So Kukubasaw Oxwell, my name is Nicholas Courtney. I'm a member of the Makah tribe, and currently just recently were promoted to a policy director at the National Congress of American Indians. I'd like to first acknowledge that I currently reside on Piscataway lands, also known as Washington, D.C. So I want to show respect to the Piscataway people who are original inhabitants of this land. Next slide. So today I'll be discussing sovereign nations and tribal governments in Indian country today. Where and what is the nation-to-nation relationship between the U.S. federal government system and tribal nations, the ITU system, and then AIAN health systems today. So look forward to engaging in this conversation. Next slide. So today there are 574 federally recognized tribal nations. Variously, these are called tribes, nations, bands, pueblos, communities, and native villages in the United States. Approximately 229 of these ethnically, culturally, and linguistically diverse nations are located in Alaska. The other federal recognized tribes are located in 35 other states. Additionally, there are state-recognized tribes located throughout the United States, recognized by their respective state government. Next slide. Native peoples and the governments have inherent rights and a political relationship with the U.S. government that does not derive from race or ethnicity. Tribal members are citizens of 3 sovereigns: their tribe, the United States, and the state in which they reside. They are also individuals in an international context with the rights afforded to any other individuals. The federal government's trust responsibilities in exchange of tribal lands are obligations to protect these lands and to encourage self-governance and to provide federal assistance to support the success of tribal communities in perpetuity. This includes healthcare, education, and other vital resources. Next slide. Today, the federal government fulfills its responsibility to provide healthcare through the Indian Health Service, also known as IHS, which is housed within the U.S. Department of Health and Human Services. IHS oversees the delivery of health services through direct IHS tribal agreements, where tribal nations and also tribal operated health centers, where tribal nations who have the capacity and resources to engage and run their own health systems. Finally, there are urban Indian health clinics, which together, these three entities make up the ITU system. Within the ITU system, IHS divides the United States into 12 regions. You can see that there are many different types of facilities and include hospitals, health centers, health stations, Alaska Village clinics, and you can see of those numbers which are run by directly by Indian Health Services, the numbers that are run and controlled more so by tribes, and then also the 74 health centers that are considered urban Indian organizations. Next slide. So today, Indian country is in a national emergency that, while intensified by COVID-19, has its roots in the federal government's neglect of its fiduciary obligations to tribal nations and their citizens. Today, American Indian and Alaska Native citizens have a life expectancy that is 5.5 years less than the U.S. all-race population. Further, American Indians and Alaska Natives continue to die at higher rates than any other Americans in many categories, including chronic liver disease, diabetes, unintentional injuries, self-harm, and chronic lower respiratory diseases. These, again, have been exacerbated by COVID-19. Next slide. So some of the unique barriers for decision makers to address social determinants and tackle health inequalities that I wanted to focus on today was the lack of general education / awareness, which leads to our invisibility in these discussions. The second would be the lack of funding for the ITU system and the federal government's inability to adequately fund our health systems as compared to other federal health systems. And then also, and very important to this conversation, is the lack of appropriate data. We're often called the asterisk nation, where within federal, state, and county and city reports are either not included at all, or if we are named, we have an asterisk next to our data because of the inability to collect a large amount. Next slide. So the first thing that I want to touch upon is the lack of general education and awareness, which therefore leads to our invisibility. As a previous K through 12 teacher, we see this from an early age and the lack of culturally relevant or even inclusive curriculum at the state level. In 2018, the Reclaiming Native Truth Project released a report and comprehensive data about challenges and opportunities that Native Americans face in educating Americans and changing public perceptions. And these findings were not surprising to those in the Native community, but the majority of Americans know little to nothing about Native Americans. I can't tell you on a personal level how many times, whether I'm in a Lyft or a cab, where folks ask, "Oh, are you Native? I thought they were all dead." Do you all still live in teepees? And just it's very clear that our education system has not adequately addressed the visibility of Native nations predating actions such as the Trail of Tears. And for us in the policy space, this is one of the biggest barriers where, and every 2 years when a new Congress comes in, we are constantly educating members of Congress, their staff, on the simple fact that we do still exist and that the federal government has trust and treaty obligations to tribal nations that have been established by Supreme Court decisions, regulations, and again, more so treaties as the ultimate law of the land. So next slide. Funding is also a big issue. And again, while COVID-19 has certainly exacerbated some of the disparities in Indian country, those disparities were occurring before COVID-19. So compared to other federal health systems, IHS is funded at a per pupil level of $3,779. This is compared to health systems like the VA or Veterans Administration, which has per pupil health funding at approximately $9,574. And further, within their Medicare system, which is a federal health system, $13,257 per pupil. So you really see just in this simple chart the lack of funding that the ITU system is getting, and how tribal nations, especially those who are controlling their own health systems, are really doing incredible and phenomenal things with the limited resources that they have. Next slide. Like other nation states, American Indian and Alaska Native tribes are decision-making entities that need reliable information for planning and development. In the current age of big data, tribal nations still rely on incomplete or inadequate data about tribal citizens and resources. This lack of reliable planning data is only one symptom of the data gap in Indian country. American Indian and Alaska Native populations remain both hard to count and hard to reach. We also experience vast data inequalities, such as being notable for the largest census undercount of any racial or ethnic group in the 2010 census. This invisibility is perpetuated by state and federal agencies and policies at each of those levels that leave American Indian and Alaska Natives out of data collection efforts, data reporting and analysis, and or public media campaigns. Next slide. So what mechanisms can be utilized to help mitigate these identified barriers? The first would be increased appropriations and full funding for the ITU system. The second would be improve the quality of and access to Native American curriculum across the country within all K through 12 schools. And then third, increase coordination with state, county, and other agencies around appropriate data and making sure that tribal nations are comfortable in controlling that data and accessing that data. This has been especially a priority and an issue in the current COVID crisis, where tribal nations have had difficulty getting data from agencies such as the CDC and working across with tribal epidemiology centers to really understand the scope of the issue that COVID-19 has brought tribal governments. Next slide. So what information and resources are used to help make decisions, and are there resources that would be more helpful to advance health equity? So in regards to the funding aspect, the National Indian Health Board provides technical assistance to the National Tribal Budget Formulation Work Group and recommends and makes recommendations to the Indian Health Service and the Secretary of HHS. Each year, that process is a year-long process where the National Indian Health Board and other Native organizations engage with each specific region to really understand a needs-based funding levels for our health systems. We know that things don't happen overnight, so have developed and tribal leaders have gotten behind the idea of fully funding the ITU system over a period of 6 to 10 years. And what does that look like? To ensure that tribes are not just given millions and hundreds of millions of dollars right away, but that they are included in the planning and the process to improve our health systems. Next slide. Further, increased visibility and allyship. The Reclaiming Native Truth is an incredible organization that is doing incredible work about changing the narrative about Native Americans. And I think, you know, and I do want to thank Mr. Izazi and Families USA, because I think that they are one organization that does good work of making and being purposeful in including American Indian and Alaskan Natives within their work. So I think just having organizations and decision makers that are participants in this event see what they can do. Everyone that is on this event is tuning in from Indigenous lands. So I encourage you to do homework, to learn about the tribes that are nearest you and what relationship building you can do with those tribal entities. Next slide. So in regards to increased visibility within education, in 2019, the National Congress of American Indians, in partnership with the National Indian Education Association and others, conducted a landscape analysis to determine the extent to which states require or provide support for Native American K-12 curricula to all public school students. And to review the policies, laws, and practices that states currently use to authorize, provide, or improve the delivery of their Native American K-12 curriculum. Our findings were that almost 90% of states surveyed said that they had current efforts underway to improve the quality and access to American Indian and Alaska Native curriculum, and a majority of state surveys indicated that Native American education is included in their content standards. However, and more importantly, far fewer states require Native American education curriculum to be taught in their public schools, and even less provide resources or work directly with tribal nations within their state or region. Next slide. So what does success look like within tribal communities? As I said earlier, of the 574 tribal nations across Indian country, that success needs to be defined by them and at the local level. Successful health systems in Alaska look very different than successful health systems in Arizona, in Massachusetts, and in Florida. So that success really needs to be defined by those local, at the local level, by those elected officials and their stakeholders. And then tribal nations must be given the tools and resources needed to obtain their definition of success. And not only do they need the tools and resources, they need to be ensured that they have the capacity of knowledge to utilize those tools and resources to fit their needs. So next steps for everyone, as I said, whose tribal lands are you currently on? There are easy ways to find that online and with other digital resources. And then also think, what tribal government is your organization coordinating with? And are you including American Indian and Alaska Native perspectives in all your work related to health equity? I just want to conclude by saying Klako, which means thank you in Makah, and it's a privilege to be with you all today. Here is my contact information, and happy to answer any questions, share resources, and again, thank you all for your time.
Thank you, Mr. Courtney. Mr. Sassi, I'll turn to you for your presentation now.
Thank you so much, Ivory, and a very big thank you to Dr. Gibbs and Mr. Courtney for their terrific presentations. So I really, this is such a terrific question that we're talking about today, which is what are the gaps that we need to fill in to get policymakers really activated around questions of health equity, particularly in the context of this just terrible COVID crisis that we're facing. So this discussion I'm about to give really is focused on, what moment are we in and how can we do things differently? A little bit, I think Autumn asked a question about this, what's missing, what's different? And it's really centered on those of us who've been working for decades on the issue of health equity and justice. How do we do things differently? This is really about how do we bring a lot more folks into the fold and make the equity imperative have currency across a lot of different interest groups and political persuasions. So let me share my screen now. Hopefully you guys can see that. Great. Okay, so let me go ahead and get started. So really quickly, folks who don't know about Families USA, we've been around for about 40 years. We believe that healthcare and health is one of the most important social justice missions that we have as a society. We work in 4 areas: healthcare equity, value, coverage, and consumer experience. We work on the national level. We're very well known in Congress and with various federal administrations, but we also work in all the states. We have state partners in every state. They're usually the leaders of consumer grass tops organizations and grassroots organizations. And we do individual projects in many states focused on trying to drive towards better health and healthcare for all. So I would say really at the center of what I'm presenting today is the notion that to succeed, a culture of health, this goal of really transforming the way that we as a society think about and achieve health, has to tap into the energy of the larger national healthcare movement. And it's really focused, if you look at what's going on right now in the public, and has been for several years, there is a real crisis around cost and access. So 44% of the public right now do not see a doctor when they need to because of cost. That's almost half of all Americans are foregoing care. 30% report that medical care interferes with their basic needs like food and housing. 3/4 of Americans feel we're not getting good value from healthcare, and almost 80% of Americans think that the government should really get involved to make sure that everyone has access to high quality, affordable healthcare. And this is playing out year after year. In the 2018 elections, 40% of voters selected healthcare as their most important issue. And even this year, obviously with the pandemic, it's gotten even more intense. So to start with, a lot of, and I'm sort of providing this information perspective. I've worked in the Senate, I've worked with industry, I've worked with governors, and now with consumer leaders. And this is really the frame that brings all of these different interest groups together. First, it's really important to acknowledge healthcare spending has been spiraling out of control for quite a long time. And here we see that between 1960 and 2018, we've gone from 5% of our GDP to almost a fifth of our GDP just on healthcare spending. And this is a chart that's very well known in DC, but it basically charts out major healthcare spending, major federal spending. And what we see is that in about 15 years, we'll spend more on healthcare than any other cost to the federal government. It's startling, and it's got a lot of policymakers' attention, both Republicans and Democrats. And this is a breakdown of all state spending. And what we see is since 1991, there's been a steady increase in the amount of money states are spending on healthcare as well. It's a budget crisis for governors and state budgets. And then most importantly, from the perspective of Families USA, it has a terrible impact on families' budgets. So what we see is that between 2002 and 2007, 7 and 12, and 12 and 27, year after year, the cost of healthcare has grown, in this case it's premium increases, has grown much more quickly than either your individual family's paychecks or inflation. And so in so many ways, either for the federal government, for states, or for families, the cost of healthcare is squeezing out all of these other priorities that we have. This is incredible, powerful political currency. And for us to get to a culture of health and to address health inequities, we have to tap into that energy. This is another cut, which is healthcare spending in the US compared to other countries. As you can see, our spending is completely out of control, much, much higher than other similarly situated countries. So for all this spending, what do we really get? And what we've woken up to as a country in the last decade or so, maybe 20 years, is that And a lot of this credit goes to Mike McGinnis and National Academies for their seminal work on this, is that in fact, we spend a lot of money and we get very poor quality care. This is one of my favorite measures to present, which is mortality amenable to healthcare. This is with work from the Commonwealth Fund, where healthcare providers examine the charts of patients and say, this person entered our system and then they passed away. And should they have, should the system have been able to save them? And what we see is back in 2004, we were, it's the light dot over here, we were behind the pack. Now we're at the very back of the pack. This is 2014. And so what we know is that you're more likely to enter the healthcare system in the US and die than these other similarly situated wealthy countries that have the resources that we have. Of course, infant mortality in the United States is far behind other countries, 2 or 3 times higher rates of infant mortality in other countries. A lot of this connects right into equity, and of course, could be addressed by this true transformative culture of health that we're fighting for. This is something that, this is a statistic I've gotten actually from Dr. McGinnis, which is female life expectancy compared to other countries. What we see is back in 1980, women in our country lived about the same, an average amount compared to other wealthy countries. But over the last, this is the last 20 or 25 years, what we see is that the life expectancy for women in our country has fallen behind all of these other nations, that our women in this nation are dying earlier. It's unforgivable. Despite spending so much money, despite having so many resources, we aren't getting things right. And you know, one of the reasons, of course, is we're currently spending an astounding amount of money, $3.6 trillion. And as Mr. Courtney was mentioning, you know, in certain segments, for example, for Native Americans through the Indian Health Service, the Urban Indian funding, we see a very small slither of this money actually going to serve their needs. And similarly in health, for public health and activities, only 3% of this $3.6 trillion is really funding in public health. When we get to health equity, when we get to a true culture of health, this has to be rebalanced. We have to move away from these very high cost centers of spending and move towards community-based public health and social services, behavioral health, the things that actually drive towards health versus discrete units of health care. And definitely wanted to touch on health equity, how much health equity has to be central to realizing a culture of health. As we've heard today, some really clear statistics. Good health and healthcare are not equally available to all in our nation, particularly for racial and ethnic minorities. I speak as the son of Cuban refugees, as a Latino, and I watch what happens in my community, of course, the African American community, the Native American community. Right now, for example, in this country, you are twice as likely to die of heart disease or stroke prematurely if you're African American. The infant mortality rate for African Americans is more than double the rate of whites, and fewer than 1/3 of adults of color with mental illness are receiving the treatment they need. This goes on and on. For example, we know that Blacks experience poorer health than whites in 24 of 29 measures, Native Americans 20 measures, Hispanics and Latinos 13 measures. And it goes on and on. The statistics and the data are there. If you're a person of color in this country, your opportunity for health is much diminished. And of course, now these are some COVID-specific statistics. As we've heard from both of our presenters, COVID is hitting our communities of color in such a horrific, truly horrific way. Right now, African Americans in our country are dying at 2.4 times the rate of whites. Native Americans are almost twice as likely to die, and Hispanics are about the same place. So what we know is COVID is impacting these communities in a much more disparate way. I think when you look at this on a state-by-state basis, data is even more startling. For example, in New Mexico, 57% of all the deaths due to COVID-19 are to American Indian and Native Americans. 57% of all deaths. In Wyoming, 30%, and in Arizona, 18%. While, for example, in Arizona, the Native American population is only 4% of the state population. So we're seeing a fourfold increased likelihood of dying from COVID-19. It's unforgivable. It's not who we should be as a nation, and it can be changed. And a central way to get there is by transforming our nation and embracing a culture of health. Also want to talk about, there's two different dimensions, which is the cost of health inequity. We know that we've got 3.5 million lost years of life because we aren't providing equal care. There's $93 billion in cost of the healthcare system and over $135 billion in economic loss due to health inequities. Even more powerfully, I want to say that we also are at a seminal moment. There's a demographic shift occurring in our country. Just last year, a majority of our kids are kids of color. And in 2045, what we know is that our entire nation will be a nation of color. Here's another cut at the same statistics. We are going to be, in short shrift, a nation of color. I'm the son of immigrants, of Latino immigrants. There's so many of us who are first generation. Our country is transforming. And now, today, the question of health inequity and reaching justice around access to health and healthcare is becoming a central question of the justice of our nation in a way it never has been before. And we have to tap into that energy. And at the center of all of this, a lot of the work that I was working on with governors at the National Governors Association before coming to Families USA was focused on how do we address these vast inequities in our system. And it really is focused on addressing the social determinants of health. Here you see them: economic stability. We've heard a lot about them. Dr. Gibbs spoke about them. Mr. Courtney spoke about them. So it's economic stability, neighborhood and physical environment, education, fiscal subsistence, community and social context, and the healthcare system. And of course, the healthcare system is a tiny fraction of all of these other factors that really drive towards health. So again, in order for us to really get there, what we have to do is redistribute our resources in a way that allow for all of these different spectrum, all of the different elements of the social determinants to be addressed and to be ameliorated. Also wanted to mention another piece of this to really fill in the gaps and get to a culture of health. We have to acknowledge that a part of the problem also is systemic racism, even within our healthcare system. And a lot of it is rooted in unconscious bias and discrimination. And at its foundation, what it acknowledges is the way our brains work, the way the neural nets in our brains are organized, the associations that we make unconsciously, automatically, and that it can drive a lot of the pervasive racism that people of color in our nation have to face. The statistics on this are very clear. About 30% of African Americans have experienced discrimination, and about 22% have actually avoided care because of the fear of discrimination. For Latinos, about 20% have experienced discrimination, about 13% of Asian Americans, and 23% of Native Americans, while 5% of white Americans report that kind of discrimination, and 16% of LGBTQ individuals. So discrimination is happening, and it also creates an enormous amount of fear in people to seek care. There's a real watershed study that was done about 20 years ago where they studied Latinos who were coming into, and because of a program, into an emergency room or medical setting. And what they found was that Hispanics who had experienced a broken bone were twice as likely to not receive painkillers as their white counterparts because of fear of drug seeking and racism in the medical professionals who were treating them. So the statistics are startling and they are very sobering. And we would argue from Families USA's perspective that transforming the way we pay for and measure care can have an enormous impact on addressing inequities and driving towards a culture of health. We have to do things, if this really works, we have to make sure that payment delivery reform addresses social determinants, builds links between health systems and communities, funds targeted interventions to address inequities, and has robust data to fill in all the gaps in our knowledge. If we're not careful, inequities will grow. And this is a really important point. Payment and delivery reform, changing the way we think about care, allowing for payments that flow to providers to care for an entire population and financially thrive when they're addressing health and not just simply units of healthcare, can be a really powerful way to invert our system and drive towards a culture of health. But if we don't do it carefully, it can also drive the system away from the most vulnerable patients because they are different and because their needs are different. So we have to be careful about risk adjustment. We have to make we have to make sure that healthcare systems are encouraged to take on quote unquote complex patients. We have to make sure there's real incentives, and the way that we collect and measure quality all account for appropriately the ways in which complex patients' needs are being addressed. We put a lot of work into this at Families USA. We have an entire health equity and value transformation task force, which is populated with the leaders of organizations who are championing the causes of communities of color. They've worked with us to develop policy guidelines for both federal and state policymakers on how they can really drive payment and delivery reform towards equity and a culture of health. There's 6 domains: payments, safety net, community partnerships, building a really transparent and effective evidence base, equity-focused measurements, and then really focusing on growing a diverse healthcare workforce. All of this is available on our website, and we encourage folks to take a look at it. I wanted to close by talking a little bit about some very new research. We went into the field with one of the leading communications and messaging leading lights in our country, Dr. Drew Weston, to look at where is the public right now on questions of racial equity, social determinants, and a culture of health. And we built messages, and we found these 3 messages, among others, had incredible power to drive the public to support reforms that were focused on racial equity, social determinants, and cultural health. They all rated 44 points or higher, 30 points or higher against negative messaging. So, and this is for Republicans, Democrats, and independents. These are messages that can unite us as a nation around all political ideology. Let me just read them to you so you can hear what they sound like. First is, all of us should have the opportunity to live a healthy life and receive high quality healthcare, regardless of our race, ethnicity, or gender. That scored 44 points above the negative messaging. The second one was living in safe communities, having the time to cook, and being able to afford healthy foods, breathing clean air are as important to our health as yearly physicals or a visit to the doctor. That scored 43 points above the negative messaging. And then finally, if there's anything we've learned from a virus that doesn't care where you come from or how much you earn, it's that any of us is sick. All of us can become sick, and we should all have access to affordable healthcare, regardless of our color, our wealth, our immigration status. That was plus 30 points against the negative messages. So there is a way for us to build a unified drive towards equity and culture of health if we are careful about the way we talk about it and we tie it to the powerful political currency that's afoot right now in this country. Ivy, that's it for my presentation. I'm very excited to take any questions towards the end of the day here.
Thank you, Mr. Asasi. And we do have some questions in the chat box, so thank you to those who have been submitting them throughout the meeting. Please continue to do so. We are going to transition into our 15-minute break. Well, a bit longer than 15 minutes. I'm sure we could all use some coffee, something to nibble on. But as you move into break, I do want to share that we're going to leave up a poll during the break time. So I'll ask Julie to put that up on your screen. And we're asking you to respond, what does it mean to advance health equity and policies and/or systems? So this will be up, available, and ongoing throughout the break. And we look forward to you joining us again at 1:15 for our next session, as well as our rounding out of the day with our speakers' reflections and our Q&A panel. Please feel free to respond to the poll and continue to respond to submit your questions through the chat box. Thank you again, and we'll see you at 1:15.